mean, that's a very small feat.
Right. Yeah, I agree. Just like something I gotta like think about, like look at. But
Yeah,
like, thank you so much for all this advice. Like, I really
that's a
appreciate it.
very
Oh, okay. So we started going live, but we'll wait like a few minutes and like let more people like join. Like we'll wait like 5 minutes so people can join. I'll put
yeah.
it up on the story so people can swipe up and join. Hello, hello to everyone who is already here. But so how was your day today? Were you in for a long time at work today or was it like a typical day? How was your
No,
day?
it was atypically terrible.
Why was it terrible?
um, just I'm so science science and objective based, but I swear, and I think anyone would, an oncologist, like things come in clusters, like different disease processes, and acute leukemia is obviously the most deadly, kind of worst thing that somebody could undergo, and I've had three in the last 48 hours. Three, and you usually go months and months without seeing one.
Mm-hmm.
So super super sick. You're in the hospital kind of overnight, and I was up here really early, went to bed at 1 a.m. last night, because acute Luke just, it's extremely high maintenance to get them through. 50% die in 48 hours from
Oh,
diagnosis
wow.
in America. 50%, half coin flip if you survive for 2 days, 48 hours after your diagnosis, because it's just so advanced and messy. So
Yeah.
that's
I
that.
can even imagine like what the death rates are in countries with less access to like
Oh,
healthcare.
acute leukemia, probably 95%. I mean, it's terrible.
Yeah. Wow. That's insane. Yeah, I could imagine why your day was pretty terrible.
Yeah, and then it's waves too. Like you have a bunch of good victories with like your stage four cancers. Everyone's doing well, and then just on the based on the cadence of when you're seeing them, and everyone starts progressing at the same time. So it's hard to have multiple conversations about bad news, and I had to make two hospice stays. So it's a lot of emotional, but it's a grab bag because just for the two people that had bad news, they could have been good news today, and so you just never know what you're in for.
Hmm. Well, thank you for talking about that. That's kind of insane, honestly, but
Yeah.
hi guys. Before we like get started, I'll just talk about like a few things and then I'll go more into the introduction. But so before we get started, I want to talk a little bit about the summaries, guys. So remember, you guys can go back and watch any session as long as it was after 2021. Our deadline will probably be towards the end of May. So you guys have a lot of time to get in those summaries. Make sure you guys type up a good 4 to 5 sentences and send it into clubmedshoe@gmail.com. But if you guys like can't figure that out right now, if you go to our Instagram and click on the bio, we have guidelines on how to get your certificates. So make sure you guys look at that. But other than that, we should go ahead and get started. So today we have Dr. Sanjay. I'm sorry, you're gonna have to pronounce your last name for me.
Janeja.
Juneja. Dr. Juneja, and he is a hematologist and a medical oncologist. And I will let him introduce himself a little bit more today.
Yeah. Well, first of all, thank you for having me. And secondly, if you're listening to this, you're in a much further place than I was at your age for sure. I wasn't nearly as assertive and proactive, and things have worked out okay, knock on wood, thus far. So I mean, I'm telling you, you're all winners, just literally for being here. It's incredible. And I'm honored to be able to speak with you. um, so we'll just roll right into it. Um, Quickly about me, to be a specialist in hematology oncology, just like cardiology, gastroenterology, you have to do internal medicine first, get board certified in that in residency, and then you go on to do your subspecialty. If you want to do just med onc, it would be 2 years after 3 years of residency. But if you want to do both, most fellowships are combined, so it's another 3 years after that. So I'm triple boarded. Some of the social media kind of educator. It all happened by happen chance, but I have about a 500,000 followers and just love educating on blood and cancer. And then I'm a founding medical partner in a pretty rapidly growing startup called drpedia.com, where we have over 1,000 experts from Harvard and everywhere, like speaking on things in their field, so that you're not lost when you're Googling things and told you have cancer all the time, which in my world, that is going to be the answer, but most of the times it's not. So we're trying to just make free, accessible healthcare information to empower, the masses without all the fluff and stuff that you can't really navigate through. And then I'm also, my wife is also a hematologist med onc. We met in med school forever ago, and we practice in Baton Rouge, Louisiana, and have 3 crazy boys. Nobody really cares about this. And then my education track. So I did my undergrad in my hometown, Louisiana State University. I got a BS in biology. I will say, you said most are in high school or college?
We have a good mix, like upper high school, lower undergrad.
Okay. So what I did, the reason I was able to accomplish, a major and 2 minors and still kind of have fun in college was obviously I took a lot of AP classes and stuff in high school, but I didn't use all my credits. So I had like 50, 70 credits I could have used and I didn't. Just kind of buffer that transition. So I just like retook, it was honors chemistry and everything in physics, but it really made the classes really easy. I kind of got to break into college experience and not, find myself in a bad situation, because those grades matter, from day one. So in that, time, I got a couple of minors in philosophy and chemistry. I was kind of was heavily on the leadership side. It doesn't have to be leadership and extracurricular and research. I mean, you just pick something you're really passionate and enthusiastic about. I can say that because I was on the med school admissions committee for years, and then I was on the committee to select our residents and our fellows. And I can tell you all we care about is like, are you concentrated and enthusiastic and passionate about what you're doing, whatever that niche or capacity is. Mine was leadership, because I love I like listening to people and understanding what can make them better people and optimize the situation. And that's what leadership is to make the best surroundings for them. That way everyone's happy, blah, blah. So anyway, that's what you'll see in my education as president of my college at LSU, Basic Sciences College, and I was president of my med school, and then I was president of like the whole residency and fellowship part in LSU, which is about 550 residents and so. And then I was chief clinical fellow, where I did my fellowship at Weiss Wildlife Cancer Center. So day-to-day life as a hematologist, oncologist, realize that it's going to be, every time you hear, well, it depends if you go academic or private. It really does. That makes a humongous difference. So academic is more, the pay structure is different than it is in the private setting. It's more facilitated towards teaching and trials and really good academic literature-based care, which I'm able to do now as a private doctor, because when you start, you have the time. And I don't, that's why my wife and I both do hemonc, because we realize to do it comprehensively in an academic way, but in the private world, it just takes more time. So you see less patients. So we want to work less our whole careers and that's less number of days to give good quality care. But we have 2 components. So hematology is complicated blood disorders. And I put all of this there because these words are foreign to most people. So when people say, what does hematology do? It's hard to explain, because if you don't know someone with a problem, or you have it yourself, you just don't know. It's polycythemias, thrombocytopenias, everything that has to do with the bone marrow. So that dark brown stuff that happens when you bite a chicken bone, that brown stuff in the middle, that's marrow. And it makes all the constituents of white blood cells and platelets and stuff. And there's all kinds of disorders in there that no one's heard of. And then I do IV replacement, which is probably the least exciting in the sense of workup, but it's very fulfilling because people's lives can just change when they get replete on their iron deficiency, especially if they've been told it's normal to be iron deficient. It's not, and you should have it replaced. And then on oncology side, obviously, I see any and all patients that are diagnosed with cancer. I don't work up cancer. Well, sometimes I do if it's incidental, but most of the time they have a diagnosis and they come to me, and then we figure out what we're going to do. So sometimes it's curative, sometimes it's most of the time it's metastatic, meaning that it's spread somewhere else. So palliative therapy does not mean it's like, oh, hospice. I mean, people live years, with palliative chemotherapy and stuff with great quality of life. If it's not standard chemotherapy, which we'll kind of talk about later. And I did it. I loved critical care because critical care was very physiologically, technical based. So I did 6 months, a little extended critical care experience in residency. but the relationship side was totally different than oncology. You didn't know your patients at all, probably didn't see them again, didn't know the social dynamics when you're having really hard conversations. Whereas in oncology, I can have very hard conversations about hospice, treatment, not treatment, what do you want to do, and know pretty much the whole dynamic of everyone in the room, because I see these people every 2 to 3 weeks, a month, for months and years. I mean, I get really close with them, me or any oncologist, because the treatments are that frequent. And you're the quarterback of management. So you're the resource that, like, I told somebody today, I'm like, you don't worry about it. That's my job. Let me stress about it. You just ask me everything you want to know, and I'll do all the research, this and the other. But, she was just crying every day about what's going to happen. And I'm like, I do all the literature. That's what my hours are for. You enjoy life, because she's incurable. And I'll just feed you all the information and let you pick all the choices, and I enjoy that, because we're all going to die, but how is the quality of life in that process? And some people call it a fortunate or not fortunate to know they have cancer, because some live life to the max, knowing kind of an idea of how long they have, and other people, are derailed with it only usually because of the psychological mental part early on. So if you can help that, that's huge.
So, real quick, a
Yeah.
question would be like, how do you deal with that mental pressure and like the stress of having to tell someone that, it's incurable? And if you have time, do you want to talk about maybe like the hardest one that like patient that you've had to talk to?
I don't know if you can handle the hardest, but I say that because I feel like I'm pretty tough in that regard, and it's hard not to talk about it without crying. But anyway, the way I handle it is first realizing that I didn't obviously give the cancer, right? Or like they just presented that way. That's what happened. God willed, whatever you want to call it. They are metastatic. So when they come to me, I see my job as, what can I do and how can I deliver this news to make it the most, like, to make them over time the most, like, confident, okay, empowered, and just like able to live with their cancer rather than their cancer owning them. Like, they own their cancer, it's part of their life, but they're in the know, they feel secure and entrusted about the person that's caring for them. If I can do all of those things the best, then I feel like I'm offering something that maybe the next person couldn't. And that's why I focus so heavily on that. I really believe, everyday people. I see everyday people become these courageous, amazing, great headspace people that I hope I could be like if I had a diagnosis. And they seem very sometimes meek or feeble or scared at first. And you just see this growth and courage. Us as human beings all have this in us to just be okay when we know what we're in for. It's terrifying to go into a water or a dark room blindfolded. It's terrifying. But if you turn the lights on and you see everything that's around or whatever, it's so much more comfortable regardless of what you have to get past to get to the other end. And that's how I see cancer. And I've seen it firsthand. The more I educate, the more empowered they feel. And you can see these huge differences. And that's how, when I go to bed at night, I'm like, I feel like I'm doing the best job I can to help them live with this without that kind of degree of fear. Now, the hardest news is not always giving the news, because if you're responsible, you're giving the best treatment care. You're reading constantly to figure out what the new kid on the block is that's most effective and least side effects. The news that's really hard is when your 25-year-old asks you, Doc, when I went into the ER 4 times and I kept saying I had, lower, abdominal pain, and I kept being told it was gas, and I went, here and there, urgent care, and I kept being whatever for the last 8 months, or the first time, 1 in 8 months. If they would have looked, or if they would have done the CT scan, could I have been cured of this? Would I have a life?
Uh-huh.
Because I see them metastatic. And then that's hard, because, like, it's so much harder to overcome what needs to be focused on when it's justified, especially for the mom or the dad or the husband, the wife, to say, like, this, they would be around if somebody would have done more, quote unquote. And
Right.
that's a whole black box of things to talk about on why it's not all just that people don't care. It's a whole bunch of things, but those are the hardest things. And I've, obviously that's why I never did pediatric oncology, because I mean, kids, especially now, but it's the young ones that, you know, it's a whole black box conversation, but it's the young ones that, like, seem like they really were proactive, they're going to lose their life because of something out of their hand,
Mm-hmm.
even though they sought it out previously.
Yeah. Well, thank you for speaking about that. I could
Yeah.
imagine like a really big part of your job to like, talk to them and motivate them and So,
Yeah, reorient them, like get their headspace, get them pumped, celebrate the victories, high five. I tell my patients that are responding well, even though I'm metastatic, I'm like, all right, like I'm still waiting for you to tell me that I need to delay your next treatment if it's every 2 weeks, because I want to hear about that vacation that you're taking and stuff. Like, you want to do that kind of thing. Like, I feel like that's your job to like make sure that they're maximizing life. Like I said, we're all finite. Some people have what some people would argue the grace of knowing that they have X amount of time. The other person gets hit by a bus, and if they would have done something differently, or me, if I got hit by a bus, they knew then they would have done things differently in their life and their relationship. So it's like you get a lot of perspective. I feel so humbled to do what I do, because no matter how bad the stresses are, every day I see like today was just a bad day with a lot of hardship for people, and it's just like a very quick reality check about like what to stress about in life.
mm-hmm. Well, thank you for sharing
Yeah,
that.
yeah, of course. All right. Day in a life. So this is like mine personally, and I want to put my personal stuff here. Like I usually get up around 6:30 a.m. Like young kids. The only time I have to work out if I can. I mean, maybe twice or thrice a week if I'm not even that much. That's a lie. But that's where the home stuff is. And then 8 to 9 a.m. I go to the hospital side. So that's inpatient. And all the people that I'm seeing while they're admitted, new cancer diagnoses, complicated blood disorders, I'm rounding on them. I'm talking to families, updating them, kind of managing them as a consultant or as a primary oncologist. We actually admit to our team. And then I just said that. And then during the day, these are the weekdays, like 9 a.m. to about 5. Excuse me. I'm seeing patients in the outpatient or clinic setting. So those are the people that are getting treatments that aren't admitted. They're not so sick that they need to be admitted, but we're giving them treatments. We're going over scans. We're seeing new diagnoses. Usually in the morning, it's all treatment based. So it's like 15 to 20 minutes, but it lasts longer, which you can't plan for if they're progressing and you got to talk about a new drug or say this is, unfortunately, there's no more options, et cetera. And then in the afternoons, I do my new patients. So those are hour visits. I get to know them, their history, formulate a plan, teach them about their cancer, et cetera. And then from 5 to 6, I go back into the hospital because a lot of people either don't get up, can't get to the hospital. Basically, family members to talk about it, and they want to talk obviously with cancer diagnoses. So I'll talk to them again, and then anything during the day when a new patient got admitted with a new cancer or new blood disorder where they had to be admitted, I'd go ahead and see those consults, and then play with the kids, do all that stuff from 6:30 to about 8:30 or 9, and put them to bed, and then this is the hard part about oncology. I mean, the notes take a lot of time because we want everyone to understand what's happening, and it's so complicated usually. And then I have to review for the next day the scans. If I'm going to give bad news, what are the new treatment options I'm going to give if they did progress, et cetera. It's pretty rough as far as the private part goes like that. And then every 5 to 6 weeks, I actually, that weekday thing, all that's the same, except I get to the hospital at 6:30 because, like I said, we admit to our oncology service, which is a little atypical for most places. So they're on my team. So I round on everyone. So 12, 15 patients, manage them, all their problems, why they're admitted, because they're acutely sick. And then I just roll into clinic. Mm-hmm. And then I have a call from Friday, 5 p.m. till Monday at 8 a.m. where I round on the patients on Saturday and Sunday. And I'm on that 96 hours or whatever call through the night. And that's no fun, but it's only every 5 to 6 weeks. Any questions?
No, but we're getting a lot of comments like this session is pretty deep and we're all gonna die is such a mood.
I mean, it's a spoiler alert, but it's like I always share that because I remember being stressed myself and everything. And we don't, but we do have a date above our head. And I'm sure all of us would just do things differently if we knew when. That's why I say that about it. Some people say it's a blessing when you have a diagnosis, about sometimes it's 2 years, 3 years, but and things just change for people. And I've heard I say that because patients have said, well, like, now I know. So I've just changed the way I'm living. So it's pretty neat, pretty big reality check. And, I would say if you're going from point A to point B and point B to C, like you should never be doing something more than a few weeks or months to when I get there. Like if you're truly not enjoying every day, I think that's, at least in Indian culture would call that like, it's just irreverent because you're not really like, appreciating those finite days that you have. I mean, that's all cultures, I guess, but Eastern, especially Buddhist and all that stuff. So there's some more depth for you. I said, there's some more depth for you.
Yeah, that's good. Just one more thing before we move on.
Yeah.
How did you know that this was for you? Like, obviously, your day is packed, like jam packed. You're spending a lot of hours doing this. So obviously you need a lot of passion and dedication to do this career. So like what keeps you going the next day? Like how did you know that this was the path for you?
So I don't know if anyone listening has experienced this, but this is oddly personal for such a big crowd. But I I always felt, and it kind of goes back to Indian culture, like I really did start to feel like sometimes you feel like you're almost like the benefactor of too much, like not fortune, but you're the benefactor of something that really is only benefiting you. So like when I got these like president roles and people like believe in me and I have the ability to communicate well and understand people and share things and when I can improve systems, you know, I would hope that most of us realize like that's mostly blessing. Like it's like, yeah, you worked on it, yeah, you did stuff, but like I didn't do anything to be able to speak well that much, right? Like I didn't take classes and stuff. It's just a gift. And a large period of time, you're gonna a lot of that stuff you're gonna feel. I hope at one point that it's in vain. It's like, why am I the only one benefiting from this? Like it just seems like, why do you got to equip me with all these things? And it's worked out, and why? Like I hope you pause and think that anything that's positive, you need to kind of realize like it's a gift for something like hard work and getting a good score is one thing, but like you don't put in hours into like having this like people having faith in you, blah blah. And I finally realized in residency, no, actually, it was in med school when I was having those longer conversations. So when you're in med school and your clinical rotations and you're an intern in residency, you have more time with families and patients. And I would try to teach, and I would, obviously gravitated to the cancer ward, and it just had a lot of reinforcement or validation because I wasn't sure. I thought I was too soft for oncology, and just family members, even when their, mom, whatever died, they were like, "You belong here." Like the way you speak, the comfort that you provide, the way you listen, which is what I learned from my dad. He's such a good listener. I was like, aha, like maybe this is why finally, like when, yeah, I did benefit to this point. I got into med school, I became president, I got into a fellowship. I'm like, this is where it comes back. This is where like it was not me benefiting. This is the universe putting that momentum and equipping me with all the tools I needed to then diffuse that into all of my direct relationships because I can help people with the hardest process of their life, both when they pass away, but especially their spouses and families. And it almost feels finally like I feel comfortable more because I know how committed I am. It's not just work for me. I really like, wake up at 1 and 2 a.m. thinking about it and what I need to look back, not stressed, but because I just want to do that. And that's what you need to do is really don't force something. If you're unsure or it feels unnatural, you really need to reevaluate. Maybe like if studying just stresses you out and you can't do those courses, maybe the world wants to will you into something that you're just going to be so amazing at that you have a need for. I get a question a lot. Well, how do you focus? How do you have discipline or make sure that you don't procrastinate? I'm like, if you're procrastinating, maybe something's willed for you. Maybe there's literally a momentum in the universe that's pulling you to something else that you're going to be just so amazing at, but you're forcing this like, triangle into a square hole. For me, I really liked sports and I actually thought about it a lot and I wanted to be a teacher and stuff, but I just kept getting moved towards having these relationships with people. And now I really do feel just, 2 years into practice, I feel fulfilled. Why? That I was just a product to deliver that.
Mm-hmm.
And that's how you avoid, people always say, oh, how do you make sure, burnout? How do you avoid burnout? This and that, the other. Just listen to the universe. That sounds so corny, but look at the tools that you've had, look at the things that you struggle with that you may be forcing and let those, waves guide you. And that's how you'll have fulfillment. That's how you avoid burnout is to not do something with friction.
Right.
Don't, if there's friction, you're going to burn out. It's going to be actually a burn.
Right.
Oh, that's a good metaphor.
That is a good metaphor. Yeah,
Right.
that's amazing advice. So you just kind of like gotta go where you gravitate towards, like let it naturally flow.
Yeah. I mean,
Yeah.
it's what you and I were talking about before we started this. I was like, if you have this nagging thing,
Mm-hmm.
don't suppress it. Listen to it. Doesn't mean you have to act on it, but like let any gut feeling or concern day to day, week to week, month to month, year to year, like let it surface. Who knows where that directs you?
Mm-hmm. Yeah, that's excellent advice. You're getting a lot of excellent feedback too. Like, you can tell in his voice that he is so great at his job. Like people are relating, like with their abilities to communicate, and they're like, why do I get this and others don't? Like, great advice. So,
Thank you.
like, you're benefiting a lot of people with this advice. So, thank you for sharing. And also, like, at any point, if you like don't feel comfortable sharing anything,
Oh
like
yeah, no,
okay. So
yeah,
that's
yeah, no. No, like I said, I share this because I didn't have someone just sit here and tell me any of these things, and it was years of like assimilating. And here you are listening to this on a Wednesday evening. Like trust me, you're going to be so great. If you're on this thing, you were so far ahead of where I was at that time, so far ahead. And then like, and this stuff, if I accomplish that, I mean, just wait to see what anyone listening to this, you specifically, can accomplish. Like it's incredible. Like you're so many steps ahead of me where I was. So it's, literally, I hate to say sky's the limit, but I mean, if you listen and you feel what's in your gut, something's going to move you in a direction that's very fulfilling and potentiated.
yeah. No, that's awesome. Like, I feel like the more you can explore different specialties or different careers, like the more exposed you are to these things, like the more you'll know what you gravitate towards. Because like, how can you gravitate towards it if you've never even like, experienced what it is? So
Right,
keep exploring,
exactly.
guys, and
It's
keep
like people that say they don't like seafood and they never tried seafood. I'm like, that's just such a dense thing to say.
right, right. Um, Someone wants to know what your TikTok handle is. So real quick, like, you want to like let me know what your TikTok is, but
Yeah.
we'll move
So my
on to
handles
the.
are the Onc Doc, so the ONC Doc, and kind of talking about piggybacking what we just said. Like I do feel like that was almost a just celestially orchestrated thing. I didn't intend on it to be this. I don't even have a Twitter, which is apparently a huge crime on social media, uh, but it's just like because like I'm able to educate on there and make cancer like desensitize cancer so people are less scared and more proactive. And I teach about anemia and stuff, and I have little anecdotes about kind of medical comedy and humor and stuff. So it is the Onc Doc on Instagram and TikTok. And then I'm starting to build a YouTube where same handle where we teach where I talk way more formally about a lot of the concepts. Like there's people that are extremely educated. I have friends that are lawyers and stuff that like still don't quite understand staging because they may not have been sat down and explained or whatever. So I'm trying to make all that accessible because again, I do believe with education and empowerment, you can really, I mean, people have to see it every day. They know and understand. And again, not opening up a black box, but there's a lot of problems with healthcare where we are transitioning away from that and people want it and need it more than ever. And that's a whole different,
Mhm.
hour series.
Yeah, but might be like I'll definitely be tuning into that and listening in on that. But thank you for sharing. And if you guys like want, go check out the handles, learn more. But again, thank you for sharing. Do you want to like get into a case study now? I'm so sorry for deviating so far off the path, but
No, this is the stuff I think again, I'm glad we did. All right. So I had this patient born in 1939. Blows your mind, right? Like older, a lot of times you see a consult, you get an idea of the person's status and what you can achieve. And he unfortunately had lung cancer. He had widespread metastatic lung cancer. I mean, dude was like 90 pounds. So what is lung cancer real quickly? I mean, understand please that any cancer was a regular cell. It's not that you caught something that is this enigmatic, alien thing. It was your normal cells that has all the thousands of normal tools and signals and stop signs that your normal cells have, but all of a sudden it gets a few mutations where all of a sudden it goes rogue and doesn't stop growing when it's supposed to, or it just like gets turned on really fast. That's why I hate the phrase cure for cancer. There will never be just one cure for all cancer because they're all different cells, they're all different stop points and everything. We may cure all cancers one day, but it's not a single entity.
mm-hmm.
And I hate when people have a stigma on people that get cancer. It blew my mind on social media when people are like, well, didn't they ask for it? Or, doesn't that just mean they were unhealthy and not like exercising or had bad like dietary habits or smoking? So I'm like, absolutely not. Obviously, a lot of cancers occur that have nothing to do with your lifestyle. That's why I mentioned those two things. There are a couple of types. We don't have to get into that. The reason lung cancer is so deadly is because you don't have problems until it's too much of a problem, like pancreatic cancer. You don't have nerve endings in your organs inside. So it has to get big enough to obstruct something, to block something, to inhibit your breathing, to make you start coughing up blood because now it's, more central. Pancreatic cancer, same thing. Like cancers are dangerous mostly because they're caught too late. And that's why there's such a mortality with lung cancer. You might have a cancer just sitting in a big balloon, but how would you know? Unless it was happened to be in a favorable place that caused some kind of pleuritis or something.
Mhm.
Um, Little pitch, I guess, real quick. 5% of people that qualify for a fully paid lung cancer screening, so this is just smokers or previous smokers in the last 10 to 15 years, only 5% get ordered. 95% people don't get it. They get their mammograms, they get their colonoscopies. Nobody talks about CT lung cancer screening. So that needs to be picked up heavily because people are dying all the time everywhere. Now, you don't have to be a radiologist or an oncologist to appreciate this. White equals cancer. That's it, period. Lung cancer. All in his chest, all in his bones, all in his liver, all in his sacrum. I mean, his literally his sacrum where he sits is completely littered in cancer, 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 cancer. 90 pounds, due to 79 years old. What do you think most people in the country, doctor, parents, family would say, like, in somebody that widely metastatic that's 90 pounds about their cancer? If somebody says we should get a biopsy and see what it is and what mutations, what we should see what it is and what treatment options are available. Tells say he's 79 years old, chemo only makes you sick, like blah, blah, blah. This was him. This heart is supposed to light up. That's actually because it was pumping. So things light up on a PET scan that are active. The bladder is also active. But notice the places that were cancerous. I mean, they're still like there, but they're dying. This was literally only 6 weeks out. That's how quickly the cancer died, and he'd already gained 30 pounds. Why? Because the purpose of this is to share with all your friends, families, and enemies. Cancer is different today than it was even 10 years ago. We have targets, receptors on cells that we can attack with almost no side effects. This dude was taking a pill, had no side effects other than a rash, which is the most common, and the cancer completely melted away. And it was that way for 14 months. I just started on second-line therapy. He's still alive and well. If he was put into hospice, like people are getting put onto every single day across the country, he would have died in a couple of weeks and had a terrible death, been thrown up. Like he was like, tons of pain, everything.
That's
You have to get a biopsy, right? You have to get a biopsy because there's plenty of things that aren't chemotherapy anymore. Okay. You can even get a biopsy for lung cancer. My wife, Lauren, had a 92-year-old widely metastatic lung cancer, came in with brain lesions. Obviously, she's 92. Why would you? But the family was like, please, if there's something. She got a biopsy from blood work. Blood work, CBC. The same way you get a CBC. You can run it on there. Sure enough, she had the same receptor. She's 8 weeks out. All the cancer's melted away. She's traveling the world with her husband because she has a second chance. And, she's 92. 99% of people would have made her hospice. Well, it's super rare, super to have this. Actually, that's not. It's about really 12 to 15%, which is a humongous number of the adenocarcinomas to just send someone to hospice. So this is all to say, I understand fully. Cancer it's its own language. Like I think I was a very good internist, so I understood a lot. GI, cardiology, ICU. Like I just studied. I loved it. Cancer, you don't even have any knowledge on cancer, like for the most part, because it's so rapid that even a general oncologist to keep up with all the different cancers, it takes me and my wife reading all the time. It's just too rapid right now, as of 2015, when molecular targets and immunotherapy and everything came out. So I'm just trying to disseminate this information the best I can on my handles and stuff, which always gets the fewest activity because I don't know why. I got to figure that out. I got to make it more sexy or appealing or whatever. However, this information can be more appealing. The information, not anything else, to be able to disseminate this. But it's a different field, and I'm actually writing maybe a book on it. We'll see. But so conclusion wise, like I said, like almost full remission. Now that he had it and he gained all of his weight back and everything, he was very comfortably put into second line, which is standard chemotherapy. Very few side effects, maybe decreased appetite a little bit, still hunting, still fishing. And this new chemotherapy is going to give him another, on average, 8 to 9 months. So he's living years out now, when he would have died in a couple of weeks, probably in most, facilities. So, like I said, how would they have treated him? Would we have pursued diagnosis? And then I really meant to color this again. Molecular mutational testing. It's just a different world than what it used to be. Chemo is poison. Standard chemo is you give enough poison to kill the fastest replicating cells, which are cancer, without giving too much to kill your slow replicating cells, which is the rest of you. So hair is fast, you lose hair. GI cells are fast, you get nauseous, you get sick. You used to get vomiting, but our nausea meds are really good now. And then you just poison them enough to kind of control it. That's why it's incurable. But now, when you have these targeted therapies, everything's changed. Melanoma, this is another big one. They put, 38-year-old basically to hospice, kind of neglected. It was rip roaring everywhere in his brain and everything. Now with melanoma, regardless of a target or not, 40%, 4 out of 10, the dude was 38, had 3 kids, he passed away. 40% will have a response to just immune therapy. It's not even chemo. And when they do, they have a near remission for 18 months. That's 18 more months of life, right? So again, some of y'all might be, oh, this is the way of events, but it's not. The concept is you are going to encounter somebody that has cancer. God forbid you, God forbid your family, but somebody. It's just that prevalent, and we're living longer. Just understand, always consider just going to an oncologist to get guidance. That's my point. High-grade lymphomas respond well, so do small cell. And then we're at Q&A.
That was amazing. Like, the scans were really cool. A lot of people liked them, but there was a question for back to your undergrad years.
Yeah.
Someone asked, are you more likely to get into a medical school in which you did undergrad? So like, let's say your undergrad also has like a medical school branch. If you're to go to that undergrad, would you be more likely to get into that grad school as well?
I don't think it's so much the institution. So like if you I went to Louisiana State University and then I did that for all my med school. I wasn't planning on doing it for residency and fellowship. My wife, and she was a year ahead of me, so we did what's called terrible term suicide match. We just applied to one place. But it's not so much the state schools I don't think care so much about the branch at all, but they do like homegrown people, if that makes sense, especially where it's a poorer state like Louisiana. Education's less. We have a big need for cancer and care. And so for that reason, I know for a fact, especially with fellowship, HEMOC is extremely competitive now, but Dr. Mansour, who taught me so much, loved that I was from Louisiana, but he's like, I really, hope and expect you to stay here to help the people that, made you who you are. And of course, that was always my plan. I'm very proud of this state. I only have one tattoo, and it's in a very uncool place, but it's the state of Louisiana. So for that reason, it helps. So if you're out of state and going to, Kansas University, I can't imagine Kansas University Med School will see that you went to undergrad, but you're actually from Texas. I don't think that's going to make a difference. Right. But people, I can't really say that, but basically the gentleman that admitted me into medical school, he did it under the pretext of, I know you're going to do, things for our community. This is when I was like a kid. I was just not anywhere where I was now. I'm surprised he had that kind of faith or recognition of me, but he did that because he wanted me to serve the community, and it worked out. And I still message him and just say how grateful I am, and that he was discerning enough to believe that, and maybe him being discerning enough to believe that helped facilitate this. I don't know, but they do care about those kind of things.
Mm-hmm. So going more to the case study, there's a lot of questions about that pill. So what type of receptor was that pill like?
Sure, yeah. So
how does it help?
Yeah, so about 40 to 45% of cancers lung cancers are what's called adenocarcinoma. Well, maybe it's not that high, but it's a lot of them. It's majority of them. Now, adenocarcinoma can have now 5 or 6 receptors. It was 4 until a year ago, and now they've increased. Receptors are proteins, and in this case, it's EGFR, epidermal growth factor receptor. 8 to 15% of the most common lung cancer type adeno will express this receptor. And this oral pill is an EGFR directed drug. So you take it and it really exploits the EGFR receptor to make the cancer cells melt away, the same way that we use hormone blockade for prostate cancer and breast cancer. If your breast cancer expresses hormone positivity, ER, estrogen, and progesterone positivity, what's going to be your treatment? The hormone blocking stuff, because it feeds on it. These receptors, EGFR, ERPR, estrogen, and progesterone, it facilitates their production. And so if you can block it, you're going to greatly improve the disease and make it starve to death until it gets smart enough in its dying phase over months to even years to say, I'm going to find another way to grow. And then all of a sudden the hormone therapy doesn't work, or EGFR doesn't work, like in this case. But take that and set fire oil and matches to it. That's where we're headed. That's what I mean by mutational and molecular testing. We're not looking at just the gross cell itself and say, oh, it's an adenocarcinoma. We're looking at what it expresses, what is in its DNA to be able to make the proteins that we can exploit and target. And that's what we do with immune therapy as well. Something called PD-L1. Everyone talks about immune therapy. It's not a silver bullet like we thought, but it works really well. And then there's one that, this is why, again, I say biopsy. It's NTRK and TRK is the only mutation ever. And it came out. And I don't know why this doesn't get more views, because it's the coolest thing. It doesn't matter what cancer type expresses NTRK. It has an 85% response if you express NTRK and you're in a remission for like almost 2 years. And it doesn't matter what the cancer is. That's called tissue agnostic. We don't have stuff like that. There are receptors that are multiple cancers that we can attack, but for the most part, like they work better in some cancers than others. And for the most part, they're irrelevant cancer to cancer. So it's like, oh, but you have KRAS and KRAS matters in lung. Doesn't matter in colon right now. So that's called a tissue agnostic receptor. And that's what we're looking at with all of this testing. What is expressed, and can we target it without having to poison the other cells?
Mhm.
You still have side effects. You know, EGFR, almost everyone has a rash because, you know, it also has a proclivity to go there. But it's just a whole different way of managing things.
Mhm. Another question about like more of case study focused. What happens if the quality of life of the patient is poor? How do you go about treatment then?
So that totally depends on the reason, right? So I had a guy today, he's too far advanced with his liver failure to really treat him. And he was kind of getting made hospice. But when I looked at the images, like I saw that like this tumor is kind of pushing on some major vessels in his liver. And I was like, well, this guy will have less potentially like less pain or less blood clot burden, which was maybe contributing to him getting a lot of fluid in his stomach, which kept him from walking around. If I would refer him to radiation and just shrink it. So it's not going to help his survival. Like his overall survival is not going to be improved. I'm not really curing the cancer, but at least I'm helping the abdominal pain, the swelling, so he can get moving more. Or if I need to give somebody, you know, pain medications because they have cancer in their hip. So it just depends on the problem. I'm not shy about, you know, I had a guy, this whole dream was to go to the Grand Canyon, and he was going and he was pretty advanced. And literally because of Corona, the trip had to be canceled. And I was like, you were going to the Grand Canyon, and even have to fly you there. And so I gave him some Adderall to be stimulated enough to be able to enjoy the thing. So that's one liberty of oncology. It's like you get so much more liberal because you're not thinking long term, months or years. You're thinking about what can I do in their day to day, and you saw the Grand Canyon, and you know, so that's, you can get very creative in that setting when people are, you know, terminal in the next couple of weeks if you want to be. So
Yeah, so it's more like focused on what can I do here and now to make their life better.
right. But my relationship with them, that's only within like a few weeks. Usually, like him, like I've been treating him for a year and a half, and he's been hunting and fishing and doing all those things. So it's like you get everything with cancer. Usually, it's good, 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 good. All of a sudden, getting better very quickly. But you got him to that good, 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 good. Where if you never went there, it would just be straight down the whole time. Instead, it's like, oh, things are down a little bit because you have a lot of cancer, and I'm giving you chemo, and then all of a sudden the cancer goes away, and then you're tolerant chemo just fine, and you're doing way better than you felt in the last couple of months.
Hmm. Um, so this is a more of a personal question. How does it affect you personally being a hematologist, oncologist? Does it ever get to you? I know we kind of like went over that, but more of like mental health wise, like does it ever just become too much on your like bad days?
Yeah, I mean, I would actually say this week is one of my harder weeks because of, I was telling you before this started, like it's just things come in waves. For the most part, again, when you can go to bed and saying like I'm doing everything I can, and am I equipping them with the knowledge, and like, you know, I'll take it to a whole nother level. Like I can tell when the patient wants to say something, but their spouse is kind of wants a different goal than what they want. And then I'll ask them, well, what do you want? Do you want to still do treatment? Because they look tired in their eyes and they look at their peace with their diagnosis and stuff. So I try to really go to that level because I want, if someone's dying, I really want them to feel they're in the driver's seat, and they take a big step back to their family because the family, you know, obviously wants them around, and they get quiet. So you do all of these kind of little things to just remind yourself, am I acting in the best interest of the patient? Like it's very easy to reflex, okay, you failed this line when you go this line. Instead, you need to ask, like, how do you feel about this? Is this like, is it like almost like this like scarlet letter that you're getting chemo? Because on the third line, we only have about 14% chance of working. Would you like to be liberated of that and not coming to this? Every now and then they say, yeah. And I'm like, well, then screw it. Like, I don't want this 14% chance of working. I'd rather you just not have to bear that then and enjoy the life the way you want to. but then it gets hard too. And I guess the hardest part is like if you start trying to take time for yourself, sometimes you start feeling guilty. I think the family, like when you go on vacation and stuff, or now I realize like it's very hard for me, and that's why my lighthearted content has just gone down because a lot of the family members we joke about TikTok, they're like, I love it, this, that, and the other, when their family's doing well. And when everything starts getting worse and it's somber and they're scared every day, and then they see a lighthearted TikTok that I'm making, even if it's at 9 o'clock at night, but on the day that I had to talk, it's almost like how could you, so like nobody's ever said that, but like, I get it. And so it's really taken an impact on even when I need that personal life the most because of how much I like give on the other side, because of what I'm trying to do and educate people on this surface, like, it's kind of limited those things. And I have guilt, I guess, about that kind of stuff. But I don't know, you just, again, it goes back to the stuff in the beginning. Like if you're listening to the waves and the momentum the universe is putting you into, and you feel right about what you're doing and you're getting feedback, the validation, you feel fulfilled, like even the hard stuff, like I don't think, you know, you're met with challenges that you can't handle. And as long as the good outweighs the bad, like you should basically. I had an OBGYN in college. No, excuse me. It was a high risk fetal specialist. And she said, I get asked all the time, like, why, what made you want to do this? Like seeing babies that are dying, telling all the time their parents that their baby didn't make it and stuff. And she goes, I realized that life isn't necessarily always about what you want to do, but if you have an ability to do something and maybe others don't, like emotionally, then it's your like ethical responsibility to do so. And she's like, because I can, not necessarily because I want to see dying babies all the time, but because I can, and there's a need for it in the community. And that always stuck with me. And that was, I mean, gosh, 15 years ago since, is it that long since college? Yeah. But it wasn't that long, 12 years. Um, that stuck with me. It's like, it's you just, do you feel right about what you're doing? Even in this path, if there's a little angst or something just doesn't feel right, like don't force it, man. Friction causes friction rubs.
Mm-hmm. Back to that same old, good old advice.
Good new advice, yeah.
Yeah, but going back to what you were saying earlier, like that would be really hard to separate your like personal life from your like your career where you're posting those lighthearted TikToks in the same day, like you gave a tough diagnosis, like I don't know, that's kind of hard. Like, where's that line that you draw? Like, how involved do you get with your work? Like,
Right.
that's just hard.
Yeah, I mean, like you really, in some ways, some people, I don't want to be a martyr, but you really should, like, yeah. But for me, at least with my social media, that lighthearted TikTok gets a ton of comments that says, I didn't know that about iron deficiency. I'm going tomorrow. Or they say, I went because of your TikTok and I feel my restless legs are gone because I'm on iron supplementation now. So like, I'm still like, at least in that way for me, I can protect because I'm doing that to facilitate information to help the trajectory and quality of life of people 100 to 1,000 times magnified than what I can do in the clinic day. I see 20 patients between 24 between hospital and here. That anemia video had 1.2 million views, and then I've had so many comments about like the, again, I told myself the moment I'm doing this stuff in vain, like I'm out, because I have more than I deserve with my wife and kids and work and patients. um Blessing me with that stuff, but that's just another extension of what, again, I feel like is trying to, again, quality of life. The cancer patient's going to pass away. The person with benign anemia because they have, heavy cycles on their menstrual cycles is going to pass away. Like I'm going to pass, we're all going to pass away. So it's not like the quality of life is more important, in one setting than the other. Every quality of life for everybody every day is important.
Mm-hmm. So just for the sake of time, just one last question. What do you do when you come across a patient who can't afford treatment? Like, how do you go about doing that? Because there's like a lot of people who can't, they're like just right above, they're like in the middle of like a um, wage, like I guess, like where you don't make enough to be able to afford treatment, but you don't make like too like little in order to qualify for, like Medicaid or Medicare. So what do you do for a patient who just can't afford the treatment?
So I don't, since I'm private, I can't see patients that aren't insured
Okay.
because the drugs are, I mean, easily, like, today's drug I gave is $13,000 a month. So it's not like I mean, there's not that I'm getting, the pharmacy company's getting. So that
Mhm.
goes back to that black box, like, or insurance company. It's like, there's see these entities that are all very, kind of self interested because they're businesses. They're not nonprofits. They're for profit businesses, and we have to play by their rules. I see none of it. The patient obviously sees none of it. And then what you can do, and I see quite a bit of Medicaid for that reason. I grew up in training all with like underprivileged on purpose because I want to help, Louisiana community.
Mhm.
And you can make a lot of calls. Like spent a lot of time making calls to Medicaid or the insurance companies or whatever, or the pharmacy companies. I've gotten free drug for a couple of months, even if I can't have it forever. Like that's 2 months that it could work, or 3 months and stuff like that. So you can do all of those things, but of course that's got to eat into that's unbillable time. So your kids see less of you to do that. That's what's tough about healthcare. My kids miss me, but everything I do that's not billable, like that's just less time my kids get to spend with dad. So like every call, every extra call that the mom wants an update and stuff, I do all that stuff now. But then I worry like my kid's not gonna get enough of me, which is why I'm trying to find this balance of being able to pay off my insane loans by having revenue come in with education and things like that. And then that way I can give good delivery to the patients that I see in 2 to 3 days a week and still be a family, father and all these things. It gets tricky. Healthcare's, I remember I was so annoyed when women said like healthcare's not what it used to be, the attendings that are kind of on the way out. And I wouldn't do it if I were you. And I just wanted to grab them by the way, call them, explain, like you can't just say some like nebulous,
Mhm.
threatening statement like that and not come back with like, accompanying that. So I'm going to leave you with that. And no, I'm kidding. But what that means is what they meant was, if I can say in 30 seconds, healthcare has a whole different like a bunch of things where they're all growing independently of each other. There's insurance, there's pharmacy companies, there's everything in DC, there's Medicare, and then there's the patient care, and there's you as a doctor. None of us are being very collaborative right now. So when I get something that says, hey, that those two patients you saw, like that's coming out of your pocket because you didn't write this, that, and the other, that's more time I have to spend in charting. If I'm spending more time in charting, because the cost of running this clinic is, for each partner, a couple $100,000. That's out of your pocket, so you have to recover that. But then if I have to spend more time charting, that's less time with the patient and less time with my kid, and that's just is one of those two things. And so that's what happens. Well, I'll work less. Well, then you're not going to be private, private practice, and then you'll be burdened by loans. So it's just all of those things. That's why it's so key that you are doing something that fulfills you. And it obviously cannot be money. That I kept hearing it's not money, money that's joke. It's true. Like that it's not what people thought it was, I guess 10, 15 years ago. Maybe I'm doing it wrong. I don't know. But I love spending the time and everything. That's where my fulfillment is. And if you have that, if you feel right about what you're doing and fulfilled and this is where you're supposed to be, that is the best insurance of anything. That goes for everything. If you feel like you need to say something to your brother or sister and you've been feeling like that, probably not a good thing. You probably should say it. That's the best insurance for your emotional health and also for your careers and going to bed at night.
Yeah, I feel like that's like the best possible advice to end this session on. So, thank you so much for everything that do great things. We love that. But thank you so much for giving up your time to speak with all of us today. You have a lot of positive feedback in the comments. I've been taking pictures. I can send them to you. But again, thank you so much. And you guys, if you guys sat through the session, make sure you guys type up that summary and send it into our email. And again, don't forget to check out the Onc Doc on TikTok, on Instagram. Go give them a follow. Very good content. I will go follow right now as well. But again, guys, make sure you guys turn your summaries in for your guys' certificates. And I will see you all next week.